Well, I'd like to welcome everybody to the annual Puri Memorial Lecture. This is, I think it's a really exciting opportunity for many of us in a number of different ways to really celebrate a legacy. And I always like to try and come up with a word or two that I think describes what the event is and what the goals of the event are. And the word I came up with in the middle of last night at dinner was legacy. And legacy, I looked up on 4 different electronic dictionaries, and I didn't like any of the definitions that they gave, but I'm going to tell you at least one of them, which is anything handed down or left from an ancestor. And there obviously are literal things that legacy can mean, the lovely family that was left, the work that's being done by everybody. But the one I wanted to really focus on is academic legacy, because for us that does have a very special meaning. And it means the sort of line of trainees or the programmatic evolution over time that is left after an individual has either retired or stepped down or moved on. And what I think the Puri gift really represents to us, and I'll let Chris refine that definition if he'd like to, is really creating that academic legacy within the lymphoma program. And as I think back over the last 3 or 4 years, over what the speakers have been able to do during their participation of a day and a half, a pretty intense day and a half, I think. We tell them to bring their workout clothes because they get a lot of mental stimulation here, but also the legacy, not just internally, but our impact on other centers through those kinds of interactions, which I think is really a credit to Chris and to the rest of the lymphoma group for really taking on that challenge, but ultimately would not be possible without the gift from the Puri family. That really, I think, again, cements that legacy of productivity and progress in the world of lymphoma. So again, a heartfelt thanks to the family for doing this. We absolutely love the fact that you're here every year as a part of this celebration, because I think it just adds a special set of importance and urgency to what we do, and we're very grateful for your being here today. And to speak more about Mr. Puri, I'm going to invite Dr. Puri to come up and say a few words to really initiate this memorial lecture. So please come on up.
Well, I'm Mridula Puri. I'm the wife of Surinder, who we are trying to honor today. I want to welcome you all to the 3rd Surinder Puri Memorial Lecture, and I am delighted that Dr. Kahl is our distinguished speaker for the occasion. Now, Surinder was diagnosed with mantle cell lymphoma about 15 years ago. It all started with the ptosis of his eyelid, and he was a very vain man who was very perturbed that he had ptosis, and as further investigations went on, unfortunately, he was diagnosed with stage 4 mantle cell lymphoma. As frightened as we were and as distraught as we were once we got our bearings together, we tried to explore how and where Surinder would get the best treatment for his disease. And we settled on Emory in the expert hands of team led by Dr. Loniel. Dr. Majmudar, who is a personal family friend, he's a retired professor of pathology at Emory and a friend of Dr. Loniel, directed us to Dr. Loniel and reassured us that we were in the best hands possible. And he was absolutely right. Surinder got state-of-the-art treatment that was available at that time. And with his resolve and his drive to beat the illness, to be the best patient he could be, and with his philosophy of living life to the fullest and funnest, he lived 12 years after the diagnosis of this horrible disease. And he enjoyed every bit of his passion for challenging engineering projects in the country. He loved to travel. He enjoyed culinary expeditions and asked for exceptions from Dr. Loniel to be able to do that in different countries. So we are very grateful that we all had wonderful 12 years of his life He was considered in remission when suddenly one evening he came home and he didn't feel well. And within 12 hours, we lost him and lost his battle. Surinder was a great patient. He was very optimistic. He ran half marathons after he had stem cell transplant. And he was a good example that patient's drive is as important in his recovery as the treatment itself. Now, we wish to do something to advance the cause of mantle cell lymphoma. And with our modest contributions, I am delighted that we have had some exceptional, outstanding researchers to come share their work and collaborate with Emory. Dr. Kahl, I was reading up on some interview you had given to Research Lymphoma Foundation. And they asked one of the questions they asked Dr. Kahl was, what advice do you have for the new doctors and researchers? And I was very touched by your response, because I think that is a response that really, it is so important for all the doctors to hear and live by. And you had three wise responses, wise words for them. One was, be the best doctor you can be, stay abreast, stay informed, be compassionate, be kind. Your number two response was, team is a critical part of progress, be a team player and be a reliable team player. And your third response was, worry less about credit and more about progress. And I was just very touched by the humanity side of your thinking and responses. You also had some advice for the patients' families. You said, be hopeful, never lose hope. There is a whole army of doctors and researchers working to improve treatment and outcome of lymphomas, and also to participate in trials and make donations that you can to advance the cause. So I really think that you are just the person to improve the future of lymphoma treatments and make lymphoma life safer. Thank you and welcome.
Well, thank you, Sagar, and thank you to the Puri family again for the generous gift that helps to make this symposium possible. Before I introduce our illustrious speaker, someone who I wish I had been getting more words of advice from, seeing how maybe I need to read up on your words of advice from the LRF. I first wanted to talk a little bit about what some of our past speakers who have given this lecture over the past couple of years and how that is connected back to Emory. So our speaker 2 years ago, Ash Alizadeh, talked about his work with circulating tumor DNA here and how that was developing. That's now developed into a project with one of our fellows, Brian Greenwell, and Jonathan Cohen, where we're now expanding and extending that work from diffuse large B-cell lymphoma into mantle cell lymphoma, where the Stanford group prior to that had not been using circulating tumor DNA in that area, and looking at ways of being able to use that to augment our clinical trials. Our last year's speaker, Mike Williams, is now engaged in 2 trials in mantle cell lymphoma, another with our fellow Brian Greenwell and with Jonathan Cohen, and moving forward in collaborative trials in both of those areas. So Brad has big shoes to fill in terms of our future collaborations, but I think he is more than up to that task. Brad has been a longstanding friend and colleague over really more than a decade of time, and comes to us as a professor from Washington University in St. Louis. Prior to that, he started his faculty career at University of Wisconsin, where he developed on the national scene both in follicular lymphoma, leading the RESORT trial, and in mantle cell lymphomas, leading early phase clinical trials at Wisconsin that are now moving into leadership at the ECOG. He's been head of one of the 3 large lymphoma groups in the United States, the Eastern Cooperative Oncology Group, the ECOG, where he leads the lymphoma group. And since Brad's arrival there, he's really transformed the way the ECOG operates making it an extraordinary collaborative group that seeks involvement from junior investigators, including Jonathan Cohen from our group, who's been very involved there and come on to take leadership in a pre-COG and ECOG trials, involving me in ECOG leadership trials, and involving many others across the United States, so that ECOG really is viewed as one of the leading collaborative groups in lymphoma and even beyond the discipline. He's also taken on international leadership in mantle cell lymphoma, where he leads the International Mantle Cell Lymphoma Working Group for the Lymphoma Research Foundation, and will be leading a conference there in March that will actually be happening here in Atlanta. So I'll bring Brad to the stage to talk to us about mantle cell lymphoma and what the state of the art is, and look forward to our future discussions and collaborations based on this work. So thanks, Brad.
So thank you very much for the very nice introduction. I want to say a couple of thank yous now, so I don't forget at the end. I want to thank Barbara for organizing everything. Today I asked her if she has a sister that I could have as my own administrative assistant. I want to thank Chris for inviting me. Chris and I have kind of grown up together in the lymphoma world, and I consider him one of my very best friends, and it was really an honor to get this invitation. And of course, the Puri family for making this all possible. Hadn't been to Emory really before these last couple of days, but I know a lot of the people here, and what I think is really amazing is how this lymphoma program is growing at an exponential rate right now. And, you know, Chris and Mary Jo had built this up over many years. And I think with Dr. Loniel's leadership and commitment to really making this one of the premier lymphoma research programs in the world, I mean, it's literally happening before our eyes right now. You know, in the last couple of years, they've added Jonathan Cohen and Gene Koff and Pam Allen. And then they got Christy Bloom this year. I mean, that's like the Golden State Warriors getting Kevin Durant. It's just an amazing team. And I guess I just want you to know, I think your money is making a huge difference here. I mean, it's making a huge difference at this place, and it really is one of the very best lymphoma programs in the world right now. So, thank you. So, with that, let's talk about mantle cell lymphoma for a little bit. And because of my role in ECOG, I spend a lot of my time thinking about big trials and practice-changing trials. It's just the way my brain is now wired to work. So you're going to sort of hear that in what I emphasize in this presentation today. Here we go. Here are my disclosures. So I want to talk a little bit about what we know about risk stratification in mantle cell lymphoma. We have both clinical and biologic risk factors that we can now identify that have some role in helping us refine treatments and certainly helping us estimate prognosis. We'll talk mostly about frontline treatment strategies today. I'll talk just a little bit about the management of relapsed refractory disease, and we'll talk about the different current approaches that are being studied in the world. I'm going to spend a few minutes talking about maintenance rituximab in mantle cell. That's an area that was of personal research interest for me for many years, still is really, and sort of update everyone on where we are with that. And then kind of bring it back at the end, talking a little bit about new agents and how you could think about incorporating new agents into frontline treatment strategies. So because mantle cell lymphoma is not the most common lymphoma in the world, it can be occasionally difficult to study. There are not a lot of randomized clinical trials telling you that option A is clearly better than option B or B is better than C. We do end up with a lot of phase 2 data in mantle cell lymphoma, and we have to make educated guesses about whether this is really a therapeutic advance or not. And that's just the reality of doing research in an uncommon disease. Here's an oversimplified version of mantle cell pathogenesis. But we know that mantle cell lymphoma arises from a a B lymphocyte that is not yet trafficked through the germinal center of a lymph node. This here, stained in brown, is the mantle zone of the germinal center, and this is where mantle cell lymphoma arises, hence the name. We know that in probably the earliest event is this 1114 translocation, which is present in virtually every case. But when you introduce this translocation to lymphocytes and put those lymphocytes into mice, they don't actually get mantle cell lymphoma. So this rearrangement is necessary but not sufficient for the development of mantle cell lymphoma. And there are other things that have to go wrong inside those cells for it to become mantle cell lymphoma. Some of those things would include mutations in genes like ATM, which is relatively frequent, and other mutations like CHIK2. We know there are mutations in BCL, and then as the disease becomes more aggressive over time, and I do think mantle cell is one of the lymphomas that is genetically and genomically more unstable than most of the other lymphomas we see. We see that the resistance really starts to develop in patients, and they get so much harder to manage in the relapse setting. So this can turn badly more quickly than other lymphomas, which I think is due to DNA instability, and these mutations really pile up and the disease can become very aggressive over time. This is kind of unreadable intentionally, and it's just one example of one paper that tried to look at recurrent mutations in mantle cell lymphoma. So here's a list, and you can see there are a lot. And really the point I wanted to make here is that there aren't a lot of mutations that are highly frequently recurrently mutated. So there's not like obvious targets if you're going to take a mutational approach to targeting therapy. The cyclin D1 mutation and the ATM mutation are the only mutations that tend to come up with relatively high frequency. So it will be a challenge to tackle this disease at the individual level if we're going to target it based on mutational profiling. Mantle cell lymphoma does have unique clinical features, much more common in men. We still have no idea why that is, so there's a great project for a fellow if you want to figure out why this disease happens so much more in men than in women. Median age is 65, which does create challenges because we know that more intensive treatment strategies tend to produce longer remissions, yet not all patients are candidate for such intensive strategies because of age and comorbidities. The vast majority of patients are diagnosed with advanced stage disease, so it's very uncommon to see people with limited stage 1 or 2 disease, and frankly, when I see it, I don't even believe it. I'm sure the disease is hiding in there elsewhere. Very commonly to be involved in the blood, the marrow, and there was a study from MD Anderson where they did endoscopy of all their mantle cell patients, above and below, and they would even biopsy normal appearing mucosa. And when taking that kind of intensive approach, they found mantle cell in 80% of the cases. So I figure if you found it in 80%, it's probably there in 100% if you biopsied enough places. And so I just assume everybody's GI tract is involved, and I really don't look there unless people have symptoms and we really need to establish the magnitude of the involvement. Elevated LDH in a minority, these symptoms in a minority. Central nervous system involvement turns out to be relatively rare. I don't think I've ever seen central nervous system involvement at diagnosis in mantle cell. I'm sure I will someday, but it just doesn't come around that often. You can start to see it at recurrence at a low level. It's generally regarded as aggressive and yet incurable. It has a natural history that's quite unique. There's really no other lymphoma that has a natural history quite like this. I've always thought the disease was kind of myeloma-ish. It's kind of a moderately aggressive and relentless lymphoma. Now, there are some patients who will come in with what we call an indolent presentation, about 20%, and those patients are candidates for unique strategies, which we'll talk about in a minute. So one bit of happy news is the survival seems to be improving for mantle cell. When I came out of my fellowship, it was 2000, and all the literature showed that the median overall survival was 3 years. So when patients asked those questions, that was the answer you had to give, not very satisfying in the year 2000. And here's an update that came out in 2009, and outcomes were improving already. And then here's an update from the European Mantle Cell Consortium, the green curve looking at outcomes in a more contemporary data set. So it does seem as though outcomes are improving for mantle cell lymphoma, probably because of better disease recognition, maybe better supportive care, judicious and selective use of stem cell transplantation, new agents like rituximab, and some of the new targeted agents that we have to help manage relapse disease. So although we're still frustrated that we're not curing mantle cell lymphoma with any regularity and we're still losing patients, we are heartened by the fact that the outcomes have improved over this 15, 17, 18-year interval, and hopefully we'll keep making progress at this rate or even faster. This is something that comes up pretty regularly, and I do think this is true, that proliferation is really one of the keys to prognosis. So this is an old study now looking at a proliferation signature in mantle cell lymphoma using Affymetrix arrays, and here's the heat map. And they looked at about 20 genes and then divided outcomes into quartiles. And patients with the most proliferative cases of mantle cell lymphoma had this prognosis with overall survival of less than 1 year. Here were patients in the middle with the more typical prognosis outcomes of about 3 years. Again, this is an old study, 2003. But there were 25% of patients who had this better outcome. These are clearly the patients with the more indolent version of the disease. So proliferation really is key in mantle cell and being able to estimate prognosis. Now, one of the challenges is we've never really had a way to do this in a trustworthy sort of way in clinical practice. You need fresh frozen tissue to do these arrays. They're expensive. But here was a really nice, I think, advance that just came out last year from David Scott and his group at the BC Cancer Agency, where they used the nanostring platform to measure RNA. The beauty of this technology is it works very well in formalin-fixed tissue. They measured 17 genes that they felt were important in proliferation. They compared it against gold standard Affymetrix arrays in frozen tissue. They had a training set, they had a validation set, and then they ran the assay in 3 different labs for reproducibility. And it could be done with relatively low levels of RNA. So I really felt like they did a nice job of convincing us that this assay is something that could be exportable. So if you look at the risk distribution by the proliferation rate, 45% of the patients were low risk, 29 intermediate, and 26% high risk. And here are the outcomes here. The blue curve is for the low risk patients. Here are the intermediate risk. Here are the high risk patients based on proliferation. Here's the training set. Here's the validation set. And I don't know how well you can see this, but I thought one of the nice things they did is they compared this then against other strategies for doing risk stratification. So again, here's the heat map. Here's the low risk patients. Here's the standard risk. Here's the high risk. How does that stack up against, say, good old Ki-67, which is sort of poor man's proliferation? It turns out the Ki-67 stain was pretty good. You can see the high risk in the dark gray definitely tended to be weighted toward the high risk by the MCL35 assay, and low risk is in this direction with, a small number of missed calls, but for the most part, it performed well. MIPI, definitely more high-risk MIPI in the red at this end, but you can see a lot of high-risk MIPI even down here, which I think tells us, we already knew, is MIPI is not the best way to assess prognosis in mantle cell lymphoma. Here's morphology. If their morphology was pleomorphic or blastoid, much more likely to be in the high-risk group. And then looked at some other things like p53 mutations and truncated cyclin D1 transcript. So it turns out there are some other ways that can give us pretty good estimates of proliferation. But I do think because of the technology, this is an assay that could become commercially available someday, and it could be a useful tool to add for purposes of risk stratification. So here's the MIPI, and this has been around for quite a while now, and it uses clinical factors to estimate risk. And so age, performance status, LDH, and white blood cell count. Here's the risk distribution, and here's outcomes for low, intermediate, and high risk. Kind of a calculated formula. You got to do it on your computer or your smartphone unless you can do logarithms in your head. This is a useful thing for estimating prognosis, although maybe not the best tool for clinical decision making. You can see that the biggest 2 of the 4 risk factors are age and performance status, and so identifying high-risk patients by age and poor performance status is not necessarily very conducive for intensifying treatment or turning up the dial on treatment. And then this paper just came out 2 years ago now from the same group that generated the MIPI. And what they did is they factored in proliferation using Ki-67. This was a very nice paper. They found that the Ki-67 really trumped morphology and growth patterns. And with just adding Ki-67 into the MIPI, you could now generate 4 risk groups. And so I do think we are going to try to use this for risk stratification in our trials going forward, at least until that MCL35 assay is more readily available. So looking at these things, I think these can be very helpful in interpreting results from single-arm studies. What you're going to see is trials that focus on younger patients are heavily enriched in low-risk MIPI. And patients that are enriched in older patients are going to be enriched in high-risk MIPI, and you really got to factor that into your interpretation when you're deciding how good a new treatment is. So it's not always helpful making decisions in clinic for those reasons I stated. It can help me when I'm on the fence. Sometimes I might have a patient where they're really on the borderline of whether they're appropriate for intensive treatment, but I'm worried about toxicities, but maybe we'll find out that their biology and their MIPI suggests they have a lower risk disease. I might be more comfortable taking that patient in a non-intensive pathway if I was really worried about what an intensive treatment will do to them from a side effect standpoint. As far as other biologic prognostic factors, I mentioned the Ki-67. Complex karyotype has also been associated with worse outcome. And this is something that just became available about 6 months ago, but I do think this is something that probably should be factored into clinical decision-making starting like right now. So this was the group from the Nordic MCL lymphoma study group, and they took all their younger patients who had been treated with intensive treatment strategies. And then they looked at outcomes by a few different biologic factors, and the ones that shook out as being important were P53 mutations and deletions. So here's the outcome, progression-free survival, and look at the curves. This is out 6, 8, 10, 12 years now, so this is really long follow-up. So here's the outcomes for non-deleted P53 patients, kind of typical. Here's the P53 deleted, definitely not as good, although there are some patients who are enjoying good long-term outcomes. But look what happens if you're P53 mutated. Typical outcome if you're unmutated, but here are the mutated patients. And honestly, it suggests to me that if you found that, if you discovered that finding in a patient, I don't know why you would take that patient to an auto transplant with that kind of expected outcome. It is not worth the toxicities. Now, I don't know what to do with those patients in all honesty, but I'm not doing that. I think you got to try something different and innovative. So I do think start checking this at baseline seems warranted. It's not a hard disease to diagnose anymore. Cyclin D1 staining is sensitive and fairly specific, and you can check for the 1114 translocation by FISH. This is one lymphoma where you don't have to have a lymph node biopsy to make the diagnosis. You can make this diagnosis off the blood or the marrow, unlike most other lymphomas where we need lymph node tissues and lots of it. Just a word on staging considerations in mantle cell. PET imaging is very useful. Almost all cases are nicely PET avid. I do marrows in most cases, although I admit that's more of an academic interest. Most people have marrow involvement, and usually the bone marrow isn't going to change your approach to the patient, but I like to know what we're starting with, and then I like to look at the end and make sure we're good to go. So I usually look at the marrow at the beginning and the end of treatment. I don't usually do the colonoscopy and the endoscopy because I assume it's involved, unless a patient was symptomatic and I was worried about the extent of the disease and wanted to have a better understanding. And then I mentioned I don't really look for central nervous system involvement at diagnosis unless somebody had symptoms. So focusing on treatment strategies now. Unfortunately, still in 2018, we consider the disease essentially incurable, and you really need a strategy. You got to think of what's best to do for this patient now, But you also have to think about what sort of options you want to have available down the road, and you want to be thinking about how you're going to manage this patient over a long period of time. So it gets into an issue of how best to sequence your therapies, like in other incurable lymphomas. If I have a patient who's older but clearly needs treatment, I usually recommend a non-intensive treatment strategy. I'll try to explain why. If I have a patient who's younger and needing treatment, I typically recommend an intensive treatment strategy. Why? I believe it produces longer first remissions, and you heard me explain how hard this disease can be to deal with that relapse. So I love to avoid relapse for as long as possible. It's still not crystal clear that intensive treatments produce an overall survival benefit. There's some controversy about that. There is a toxicity trade-off, of course, and patients who go through intensive treatments have to pay a price in the short term with all that toxic treatment. Hopefully, they're rewarded later with a longer remission and the ability to avoid treatment, second-line treatment for a longer period of time. And then for patients on the fence, I try to factor in the MIPI and the Ki-67 to help guide me. It is okay to watch and wait in mantle cell lymphoma. This is a study from Cornell, and the blue curve are patients who started out on observation. The yellow curve are patients who were treated immediately, and at least this shows there was no detrimental effect by starting a patient out on a strategy of observation. So maybe, I don't know, 10, 15, 20% of the patients who walk through the door will have low tumor burden, they're asymptomatic, their disease was found incidentally, and you don't find anything bad on staging. That's the kind of patient you might say, well, let's just start watching you really closely, and we'll initiate treatment when we think we need to. You know, sometimes you can go 1, 2, 3 years, sometimes even longer with that kind of approach. And I think as part of your overall strategy, it's perfectly acceptable to do that. So here's a patient, a real patient, 70-year-old gentleman who came in with pretty significant adenopathy, big disease in the retroperitoneum here. And the biopsy shows mantle cell lymphoma with strong cyclin D1 staining, and the marrow is involved. No surprises there. And so I just listed some management options for an older mantle cell patient. So I'm going to let you look at those while I take one drink of water here. So I'm going to go through those quickly and talk about what I think is really the state of the state in 2018. So I generally am not a fan of intensive treatment strategies nowadays for older mantle cell patients. There's actually not a lot of literature looking at intensive treatment in older patients. What little there is, here's data from MD Anderson looking at conventional hyper-CVAD. And they separated their outcomes for patients under 65 and over 65. And the over 65, they got a median progression-free survival of 3 years. And at the time, they said, see, this is good. This is better than what you normally get. And the University of Pennsylvania, same thing. They looked at their older patients, median age 65, R-CHOP plus auto transplant or hyper-CVAD, median progression-free survival 3.2 years. Again, to them, this was justification. I'm going to show you, I think we can get 3 years with non-intensive strategies pretty easily nowadays. So for older patients who do less well with these intensive approaches, I think we can get them that with in a less morbid way nowadays. So R-CHOP, this gets pretty consistent results. Just about every study that's looked at R-CHOP gets you about 14, 16, 18 months median progression-free survival, and a big international trial recapitulated that. So if you want to use an anthracycline-based regimen, I would think you'd be better off with something like the VR-CAP regimen. They replaced vincristine with bortezomib, which is reasonably active in mantle cell, and you can see it improve the progression-free survival with a median of 24 months. My preferred approach for older patients has been bendamustine rituximab for the last probably 7 years or so. Really, this came out of the STILL trial, which gave us the first hint that this might be a better platform. These are not large numbers of patients, but this is all we had at the time to go on, and we knew our CHOP was pretty ineffective. So median age here is 70. And you can see our CHOP got a pretty typical result, 22 months. Here was the BR curve in red, and the median progression-free survival, at least in this study, was 35 months. So a suggestion that BR could be better than our CHOP as a platform to build upon. Now, there was a North American trial asking a similar question called the BRIGHT study, and long-term follow-up from this was just presented at ASCO last year, 2016. Here's the indolent lymphoma curve, and this is BR in orange, beating R-CHOP, RCVP by a small amount. Here's the mantle cell curve, and again, R-CHOP, RCVP doesn't do so hot, but BR looks better with something close to 40 months for a median progression-free survival. Again, admittedly, small numbers of patients here, 37 in each arm, but it was all we had to go on at the time. But more evidence that BR could be a better platform for older patients. And then here's an important data set that came from Matthias Rummel. This was presented at ASCO in 2016. This was a study where they were really trying to test maintenance. But there were a number of patients who just got BR with no maintenance. So I asked him once for those curves just so I could see how they're doing. And there were actually 106 patients, median age of 70, and the median progression-free survival for these 106 patients who got BR and no maintenance therapy was 43 months. Now, other groups have tried to build upon this BR platform, and there's a regimen that's been published now from a group in Italy called RBAC, where they add in kind of lowish or intermediate dose cytarabine. They first started out with cytarabine at 800 milligrams, a little too toxic, so then they came back in with 500 milligrams. And the results are pretty good. Here's the progression-free survival, and it's holding up pretty nicely at 3 years. It'll be nice to see this with a little bit longer follow-up. I've used this regimen a few times. I do find it quite hard on the marrow, so I'm not sure this is for everybody. And it'll be interesting to see how this data pans out with longer follow-up and maybe some bigger trials. So here's kind of summary of non-intensive strategies. And again, I'm just talking about induction. I'm not talking about the impact of maintenance at all. Our CHOP, not the greatest. BR cap, a little bit better. BR, if you pool those 3 studies I showed you, you get something in this range for median progression-free survival. And then I think we need a little more time and experience to know if this RBAC might be a better platform. So I'm still a fan right now of BR as sort of my go-to regimen when I have an older patient and we're trying to figure out what to give them. Now here's some interesting data. This was published a couple of years ago in the New England Journal of Medicine from Cornell and a few other centers looking at rituximab lenalidomide, frontline treatment mantle cell lymphoma. This wasn't limited to older patients. They had a mixture of younger and older, but it is certainly a non-intensive treatment strategy and something that you can give to older mantle cell patients. And they gave us an update. They gave us an update of that at ASH this year. This is just the regimen. There's so many versions of lenalidomide rituximab out there. I thought it'd be worth just showing it to you. The lenalidomide is 20 milligrams given 3 out of every 4 weeks for the first year. And then patients would go into a maintenance phase where the lenalidomide dose gets dropped a little bit. And then the goal was to get 3 years into patients, although they could continue beyond 3 years if they wanted to, and then they get rituximab all along the way. So good to see the bookkeeping. 38 patients started in it. A few dropped out along the way. 33 made it to maintenance. Some people opted to stay on the treatment past 3 years. 1 on just lenalidomide alone, 14 on the doublet, and 4 on just rituximab. And they showed us the toxicities. And this is one of the things you really have to try to factor in for the decision making. Now these patients are on treatment chronically, 3 years continually. The red is during induction, the purple is during the maintenance. So there are ongoing low-level toxicities that could have a significant effect on a patient's quality of life. So I do think this regimen looks promising, and here's the progression-free survival curve looking very good now at 3 and 4 years. But probably should be compared to standard type therapy head-to-head. Jonathan, this would be an excellent thing to do in the groups for older patients if we want to circle back to that, how we're going to follow up our current trial. This could be an experimental arm, and I do think this regimen probably deserves to be put to the test in a big trial where there's less issues with patient selection. So just to summarize, older patient strategies, I think the R-squared regimen looks pretty good. Could be some issues of patient selection. You have to be careful about that. As you heard, I'm not a big fan of R-CHOP. I like BR better. BR cap is reasonable. And I spend a lot of time thinking about how you might improve BR because there's plenty of room for improvement. So this R-back regimen is one strategy that is interesting. I worry about myelosuppression, so I'm personally not interested in developing that further, but I think other people are, and they should. I'll show you a schema in a second where we're testing bortezomib, that's the V for Velcade, on a BR backbone. And then there are some important industry-sponsored trials that are underway. The SHINE trial, which is now completed enrollment, tests ibrutinib, the BTK inhibitor ibrutinib, on the BR backbone. And there's a current trial testing acalabrutinib on the BR backbone, the new BTK inhibitor. And then in PRECOG, the organization that I'm a part of, we're going to test venetoclax, which is a novel BCL2 inhibitor on the BR backbone. And Jonathan Cohen here at Emory is going to test venetoclax on bendamustine plus obinutuzumab, a novel anti-CD20. So lots of good strategies being tested to see if they give us a signal of whether that could become a new standard of care. So I'm going to talk for just a minute about maintenance therapy. It turns out it's pretty easy to get mantle cell patients in remission. It's harder to keep them there. So this is a disease where maintenance is a reasonable strategy. So I've had a long-standing interest in this, and this was, I think this was the first paper ever published looking at maintenance rituximab in frontline mantle cell, and we had done this in the Wisconsin Oncology Network, and we had a result that we thought was pretty good because our chemo backbone wasn't that intense. It was kind of a watered-down version of hyper-CVAD without the methotrexate and the cytarabine, and we got 37 months, which was way better than you would get with our CHOP. So we thought maybe we saw a signal there that maintenance could help extend remissions and do so in a fairly non-toxic way. So we did another trial. This was right around the time Velcade or bortezomib became available. So we wanted to build that in. In retrospect, we should have pulled the vincristine out totally. Didn't know that at the time. So we included both agents, and then we really tried to push the maintenance envelope, so we did it for 5 years in the second trial. And that was published a few years later, and actually these curves were even better. Now, we didn't know if it was the bortezomib or was it the longer maintenance, because we changed two things. Another note to fellows, change one thing at a time so you can sort it out later. But we did do a long-term follow-up that was presented at ASH in 2016, and it is kind of interesting. None of these patients got transplanted, no intensive therapy, with pretty long follow-up now, we're getting out to 5, 6, 7, 8, many patients out 8, 9, 10 years, no transplant, and we haven't had any relapses after 5 years, at least so far. So maybe a suggestion that prolonged maintenance could be beneficial, although that did come at a price. We did start to have patients drop out due to recurrent infections, and there definitely was some maintenance fatigue from patients and from doctors. It just gets old after a while, having to constantly come in for treatment. So I still don't know what the optimal duration of maintenance is, and that's an open question still. But we thought this VCR-CVAD induction was pretty interesting, and we liked the maintenance, so we took it to ECOG. Now, we scaled the maintenance back to 2 years to get away from the 5-year fatigue factor. And we knew that a lot of physicians would prefer to take their patients to auto-transplant. So we wrote the trial that after the induction, if you wanted to go to auto-transplant, be my guest, or get maintenance. It was one or the other back then. And we did long-term follow-up of that and presented at Lugano last year. So these are the progression-free survival curves. And what's interesting to me is that the auto-transplant and the maintenance curves are just right on top of each other. And if you look at MIPI and age and everything, the transplanted patients were younger and had more favorable MIPI scores. So It's not patient selection that made the maintenance perform this well. What it says to me is maintenance rituximab is pretty powerful in mantle cell, and it pulled that curve up as much as a stem cell transplant pulls the curve up. That's what it said to me. So now other groups have gone on to test maintenance in randomized clinical trials. Here's the European Mantle Cell Consortium, big study published in New England Journal of Medicine after R-CHOP, which is a pretty not optimal induction, but you can see here there's a big response remission duration benefit, and there was actually an overall survival benefit for maintenance. So this study really proved maintenance is beneficial in mantle cell lymphoma. But what if you give BR, like I do? Really no evidence that maintenance after BR is helpful. So this was a trial published or presented by Dr. Rummel at ASCO, and I showed you the non-maintenance curve a minute ago. So they had 168 patients, only 122 made it to randomization, so we end up with only 60 patients in each arm, so I worry about it a little bit. But the conclusion from this trial was that maintenance rituximab is not beneficial after BR. This is the maintenance curve in blue, and this is the no maintenance curve in red. So this could be true. This could be correct, and it's possible that I've been giving maintenance ill-advised the past 7 years to my patients. I have to admit, this trial, I just don't trust it. This curve looks so funny to me with this huge drop-off right here and only 60 patients in each arm. So I'm admitting to you I'm continuing to give maintenance, even though the data would suggest that I shouldn't, because I don't believe it. Now, I might be proven wrong someday. I might be proven right. I don't know. But my final thoughts on that are that maintenance rituximab after R-CHOP clearly improves progression-free survival and overall survival in a major way, but R-CHOP is a relatively weak induction, so it's easy to show improvement if your induction is weak. BR looks like a better platform than R-CHOP. It is not clear that maintenance after BR is similarly beneficial. I'm continuing to do it. I know lots of other people are, so the jury is still out. I'm not alone in that. This requires more study, and we might get some clues on this from an intergroup trial that we did in ECOG and SWOG and Alliance. This was a trial that enrolled almost 400 patients. It's fully enrolled, and we expect to get the readout from this later this calendar year, so I'm pretty anxious to see this data. I have no idea what it shows so far. They tested the contribution of bortezomib in the induction. Now, everybody got maintenance rituximab, so it wasn't randomized to maintenance or no maintenance, but we'll be able to at least see what maintenance does after BR and compare it to other studies. And then we tested what lenalidomide can do as part of a maintenance strategy. So two important questions in a frontline mantle cell trial, specifically designed for older mantle cell patients. Maintenance rituximab has now been shown to be beneficial after intensive therapy. So this was published just a few months ago in the New England Journal of Medicine, where they randomized patients after an intensive induction, high-dose cytarabine, containing regimen, an R-beam transplant. Patients randomized to observation or maintenance. They did it for 3 years in this instance. I just show this to remind you, this is very typical for a younger mantle cell trial. Half the patients are low risk. So these curves always look better in the young patient studies. But here's the rituximab arm, here's the no rituximab arm for progression-free survival, and here's overall survival. So once again, rituximab as a maintenance strategy in mantle cell lymphoma shows a pretty profound impact, and I never would have predicted this, that you could show improvement after auto transplant. I thought the curves were already pretty high, and to try to pull them up further was a really tall order. So I would not have guessed this result, and good for them for making that discovery. So we're trying to design trials for younger patients with mantle cell in the cooperative groups, and this has proven to be a real challenge. It turns out everybody's practice pattern is all over the map, and trying to get some sort of consensus on an induction strategy is just about impossible. And I had sent out a poll to every lymphoma person I know saying, what do you use, what do you use, what do you use? And here's just a smattering of the answers. Some people like hyper-CVAD without a transplant. Some people give a short course of hyper-CVAD with a transplant. Some people will do R-CHOP with a transplant. Some people will do R-CHOP alternating R-DHAP plus a transplant. I tend to use the Nordic regimen. Some people are now using BR followed by a transplant. And some people don't even do the transplant part anymore. They just do a non-intensive strategy. So all these things, well, if you were a 55-year-old with mantle cell lymphoma and you went to 6 different centers, you could easily get these 6 answers right now for this is how we do it here. So I'm really interested in establishing a North American standard that we could get behind and then start to test novel strategies in a logical, systematic way. That's one of my goals before I retire, is to get that done. So we're working on it right now. It's been a struggle. As far as what I'm saying is younger, I'm declaring 65. All the European trials that have looked at intensive strategies have drawn the cutoff at that age. And they obviously have to be fit enough to get a stem cell transplant. And I'm saying intensive is anything that includes an auto transplant or something that's in the hyper-CVAD realm where you do that for 6 to 8 cycles. That's intensive in my opinion. So what do intensive strategies get you? Well, conventional hyper-CVAD in under 65, about 5.5 years. A CALGB regimen that was used for many years, about 5 years median. R-CHOP plus auto transplant, about 5 years median. All these things are pretty consistent. But when you add high-dose cytarabine into the induction, suddenly outcomes seem to improve. So here's results from a randomized trial. I'll show you the curves in a second, but the median progression-free survival is up around 9 years. Here was the pilot study that led to this study. They got 7 years for the median progression-free survival. You might be saying, why are they 2 years different? Well, you can see this curve. It's plateauing right at the 50% line. So just a couple of events could change this number dramatically. So I don't know if 9 years is real yet. Time will tell. But at a minimum, we're up to 7 years median progression-free survival. And here's the Nordic, got 8.5 with a similar sort of intensive strategy. So I think this is what I quote patients now. And if I'm going to take them through an intensive treatment strategy, we're going to go intensive, and we're going to give them high-dose cytarabine, and we're going to do the auto transplant, and we're going to try to buy them the longest remission we can possibly get them. Here are the curves from that randomized trial I just showed you. This is R-CHOP auto transplant. Here's R-CHOP with alternating R-DHAP auto transplant. Big progression-free survival benefit. Overall survival benefit was not statistically significant. Here's my off-study regimen, which is Nordic. I just find it a little easier than to include the platinum agent, but I don't have strong feelings about that. They both seem reasonable. So for younger mantle cell patients, I think I just said this, when it's time to treat, we really try to maximize the length of the first remission. If you just get the average result, you're going to get 7 or 8 years. And that's 7 or 8 years for the field to move forward, to figure out better ways, so that when the disease does come back, hopefully you're smarter and you've got better things you can do. So I mentioned how I'm trying to find a regimen that I can get everybody to coalesce behind. I was intrigued by this study that the Dana-Farber published not too long ago. And they took, it basically wanted to include high-dose cytarabine because of the value it was showing, but they also believed that Benda rituximab was a good platform. And so they did 3 cycles of BR, followed by 3 cycles of the high-dose cytarabine. They got a really outstanding result. Very short follow-up here. This is 12 months, 15 months. But pretty much everybody went into remission, and they were able to collect on everybody. And I thought, well, there's maybe something that people could get behind. It was sort of a regimen in a brown paper bag that nobody was wedded to. And so what I decided to do is do a little pilot at WashU. So one of the nice things is our division pays for our fellows to do 1 trial during their fellowship. And this was an idea that no company was ever going to pay for. So I talked to one of our fellows about just taking the Dana-Farber version, but just alternating the cycles, because the way Dana-Farber did it was the easy cycles first, and then the 3 hard cycles, and then the transplant. And just talking to Ann LaCase at Dana-Farber, she's like, it gets really hard at the end trying to do those cytarabine cycles consecutively. So I said to the fellow, let's just do 15 patient pilot study with alternating, prove to the world that you can still collect stem cells, and then let's take it to the groups. So this is Natasha Edwin. I always tease her. I said this is going to be called the Edwin regimen when it's used all over the world. So we're hoping that we can bring this forward. We've enrolled 14 patients to date, the response rates are just what you would expect, and we haven't had trouble collecting stem cells on anybody. So we're trying to bring this forward now to the U.S. intergroup as a sort of a generic backbone that people could get behind. As far as novel approaches for relapsed mantle cell, here are some of the agents that have been developed in the last few years. Bortezomib has been around for over 10 years now. At the time, this was a major breakthrough. Nowadays, this doesn't look so hot, 33% response rate. Temsirolimus is approved in Europe. Lenalidomide has pretty good activity in mantle cell. It works a lot better when you give it with rituximab. Idelalisib, decent response rate, but not durable. But ibrutinib ended up being the first really promising breakthrough with a high response rate and reasonable durability. Acalabrutinib was just approved a couple of months ago. I'm not going to show any of this data today, but it's hard to know for certain because it hasn't been compared head-to-head to ibrutinib. It appears to be a little better tolerated, and it may have a slightly higher CR rate. I would like to get more experience with acalabrutinib, so I plan on using this for a while just till I get a better feel for it. And then an agent that we're excited about that I mentioned earlier, I should update this slide, ABT-199 is venetoclax. That's the BCL2 inhibitor that Jonathan and others are studying right now. In mantle cell, it's quite active as a single agent, and because of its mechanism and how it may lower the cell's apoptotic threshold, this is a logical agent to use in combination, even with conventional cytotoxic chemotherapy. So excited to see how ibrutinib, acalabrutinib, and venetoclax partner with standard treatments like BR chemotherapy. So here's the intergroup induction concept that I mentioned a minute ago. We have BR alternating with high-dose cytarabine. I called that the Edwin regimen. And then we're going to do that regimen plus acalabrutinib. At least that's what we're proposing for the U.S. intergroup. I have another fellow who's going to help us pilot this, so I'm going to call that the Guy regimen for now. There he is. And then, you know, maybe the BTK inhibitor is so potent that you don't need the high-dose cytarabine anymore. That's an interesting question. So we decided to put in a third arm, which will be bendamustine rituximab without the high-dose cytarabine plus the BTK inhibitor. So this would be a randomized phase 2 3-arm study that we're hoping to get through the U.S. intergroup. We got approval from the ECOG executive review last week. So now it has to go through the U.S. steering committee, cross your fingers, to see if that can go forward. And the whole idea here is that this trial, which is just induction, no maintenance, no transplant, it's just the 6-month induction with the primary endpoint of the MRD negative CR rate. So we want to see what proportion of patients we get into complete remission and how many of those are MRD negative. Why do we care about that? Because just this last year we launched an intergroup trial looking at consolidation strategies. So the trial that I just showed you here would feed into this trial. So there's Christy. See, Christy, I got your institution right and everything. Updated the slides. So I think people here understand the concept of minimal residual disease. It represents a deeper, high-quality remission. And data suggests that if you're in an MRD negative remission, that's better than being in an MRD positive remission. Not too hard to understand why that might be. So it's an important endpoint, and it predicts for better outcomes. So the question that we thought was worth asking is, if your induction has gotten you into an MRD negative complete remission, how much does the transplant benefit that patient? Is this an opportunity for sort of a personalized approach in which you could ask a rational de-intensification of therapy question? So whether this trial is going to fly or not, I will admit I'm nervous about. because it's asking a big question that I'm still not sure how comfortable doctors and patients are going to be with this, but this is how it'll work. Patients can go through any induction at all, and at the end, they will be assessed for remission status and MRD status using the adaptive clonoSEQ test. And patients who are not in a complete remission or who are MRD positive or who do not have an informative ID test will just go get an auto transplant and 3 years of maintenance, which is the current standard. The patients who are in the deep, high-quality remission from their induction will be randomized to maintenance rituximab for 3 years or auto stem cell transplant plus maintenance rituximab for 3 years. The primary endpoint is overall survival, but it is going to look at progression-free survival at 4 years as an important secondary endpoint. The trial was just activated a few months ago, and hopefully people will support it. But we think it's an important question that is worth asking. Just looking at the horizon, for older mantle cell patients, I think important trials that should read out relatively soon are the SHINE trial, BR plus minus ibrutinib, and the trial I showed you, E1411. And we're anxious to develop the next intergroup trial for older mantle cell patients, but we really can't do that until we get these readouts and we know, what directions we should go. For younger mantle cell patients, I just showed you the schema for this MRD-based treatment assignment. I showed you the induction trial that we're hoping to get through the steering committee. And then there is an important trial happening in Europe right now, which is worth looking at for a second, called the Triangle trial. They use their standard approach in Europe, R-CHOP, R-DHAP, auto transplant, but they are looking at the contribution of ibrutinib to induction plus ibrutinib as maintenance. And then in the third arm, ibrutinib in induction and maintenance, but they've also subtracted out the stem cell transplant. And this trial is accruing patients as we speak. So I think this will be a very important trial for the field. So in conclusion, I do feel confident that outcomes are improving in mantle cell lymphoma. We're getting better at risk stratification using clinical and biologic tools. Older patients, I think, can be managed much better nowadays than we could previously with non-intensive treatment strategies. Younger patients, I'm favoring intensive treatment strategies. We have a number of targeted agents that are very promising, and now the challenge is figuring out how to incorporate those agents into treatment paradigms. And that's really the next, that'll keep us busy for many years. So with that, I'll stop, and I'd be happy to take any questions.